Sometimes when I listen,
Loading. One of those mornings. Okay, be good to.
Good morning, everybody. So we'll go ahead and call to order at 9:09 a.m. Could you do the roll call, please?
Good morning, everyone. This is for, sorry. Okay, so this is for roll call. We are going to start with the employee organizations first and then management. Shauna Janeway in for Janita.
Here.
Marlene Fonseca.
Here.
Chad Bogio. Esteban Lazaro.
I'm here on Zoom and I'm not sure if that's proper. My apologies.
Thank you, Chad. Esteban Lazaro.
No, that's not Chad. Chad actually is not able to make it. He's in county bargaining. This is Lizardo.
Oh.
I had a quick conversation with him this morning. I'm actually feeling
sorry.
very ill. Sorry?
Esteban, thank you. Okay. Lisa Palome.
Here.
Okay. Now for management, Gracie Liu. Tony Royster.
Here.
Matt Crawford in for Matthew Rumney.
Here.
Paul Girard in for Matt Sizebo.
Present.
Petty Santos in for Holly Walcott. Okay, we have quorum.
Member online, I mean,
Yes.
but is there a cause for him to be participating remotely? Home is fine, but for a member to participate remotely, they have to be eligible under the exceptions. So if it's a health emergency or a personal emergency for which he needs to participate remotely, otherwise he cannot participate remotely. So can we ask, did he alert staff of, no? Yeah. Okay, so unless there's if there's a reason for which he can articulate as to why he has to participate remotely based on exigent circumstances, for emergency circumstances or health reasons, he can, otherwise he's unable to participate remotely.
Okay, and I appreciate that. I mostly jumped on to make sure that we had a quorum, but I think we do. Otherwise, I'm just not up to it.
Thank you, Esteban.
So if you guys have a quorum, I'd love to be able to drop off. I just wanted to make sure, because I knew we had 2 action items, that it wouldn't be my fault if we wouldn't be able to take them.
Yes, we do have, yes, we have quorum in person.
Okay, perfect then. Thanks. If you guys are okay, I just wanted to make sure it's good. Part of the reason why I did that is I had a brief conversation with Chad Bojo this morning, and I knew that he was not going to be able to make it. So I appreciate you guys are going. I will leave you alone. Have a great meeting, everybody.
Thank you. Okay, going to public comments. Do we have any public comments?
For the attendees on the phone, please press the *9 on your phone to be placed in line for the speaker queue. For attendees in the room, please bring your speaker card to the front desk. Okay, looks like there are no attendees in queue or in person.
Okay, thank you. So we can move on to the first action item, committee report 2508 on the ballot bug. I'm gonna go with conference.
Good morning, JLMBC members. This is Robian Jamalis, Benefits Analyst at the Employee Benefits Division. Here to present the report on the State and Local Government Benefits Association, or SALGBA, membership and annual conference. Multiple vendors have suggested that LAWell staff look into the SALGBA organization as a resource for employee benefits administration. SALGBA claims to be the only organization focused solely on public sector benefit professionals. The membership brochure is included as attachment A. SALGBA offers 2 levels of membership, public sector members and business entity members. We plan to select the public sector membership level for a cost of $200. Becoming a member also allows those interested to attend the conference at the lower registration fee of $4.95 compared to $5.95 for non-members to be eligible for the early bird rate. Those interested may attend the conference in person at St. Louis, Missouri from Monday, April 28 to Thursday, May 1st, 2025. We recommend that the JLMBC approve the necessary funding from the Employee Benefits Trust Fund for any interested JLMBC members and or staff for Southville Public Sector membership and to attend the April 2025 conference in person in St. Louis, Missouri. More information about the conference is included in attachment B. Information on travel expenses are listed in the body of the report. And I will be sending an email later today to confirm attendance for this event. Please respond by March 13, 2025 if you are interested in attending. Are there any questions?
There's no questions from, Mr. Commission?
Second.
All right, so we go ahead and do the roll call vote, please.
That's fine. Oh, okay, thank you.
Thank you. Okay. Moving with the roll call for vote, starting with employee organization and then management. Shauna for Janita.
Aye.
Aye. Marlene Fonseca.
Aye.
Aye. Lisa Palumbi.
Aye.
Aye. Tony Royster.
Aye.
Matthew Crawford.
Aye.
Paul Girard.
Aye.
And Petty Santos for Holly.
Aye.
The ayes have it.
Thank you. Moving on to the next, action item, committee report 2509 on the IABP conference.
Good morning again. This is Roby Ann Jamalis. I'll be presenting the report on the 71st Annual Employee Benefits Conference. Members may attend in person or virtually at the IFEBB conference in Honolulu, Hawaii from Sunday, November 9 to Wednesday, November 12, 2025. We recommend that JLMBC approve the necessary funding from the Employee Benefits Trust Fund for up to 2 interested JLMBC members and 2 staff to attend the November 2025 IFEBB conference in person in Honolulu, Hawaii, or any JLMBC members or staff to attend virtually. More information about the conference will become available in the summer and can be delivered to you upon request. Information on travel expenses are listed in the body of the report. I'll also be sending an email later today to inquire about your attendance to this conference. Please respond by Thursday, March 27, 2025, if you are interested in attending. Happy to answer any questions you may have.
I have a question. This is a change in past practice where the elements from a difference between this and the previous report in that it's limiting the number of attendees.
Correct, yes, with the estimation, the expense estimates for this particular conference is much higher than past conferences. Hawaii has their own many tourists and additional taxes that they impose upon tourists. So we were just trying to be mindful of that, and as well as making sure that not everybody in the office leaves, but we can definitely make accommodations or take any inquiries.
Well, I mean, personally, I would disagree with limiting that since the registration cost is the same. And I know in previous conferences, many of the sessions that I've been interested in have not been offered virtually. And so had I attended those virtually, I would not have been able to access all of those sessions. So you pay the same registration fee, but you get frankly less out of it when you do it virtually. So I don't think that it's as comprehensive
Right.
as it would be if you do go in person.
Thanks for that feedback. That's actually
Yeah.
something that we should bring up to IFEBP.
Yeah, because they started doing, offering the virtual option over the last few years, obviously because of COVID, and then they continued doing kind of a hybrid for the last few years.
Right.
And I have noticed, when I've tried to schedule different things and figure out how to do it, looking at what's offered virtually and what's not, there's definitely a big discrepancy. I don't know if that's going to be the same this year, and I don't think we'll know that until after all of the arrangements are
Right.
made. So we kind of have to go on the assumption of what's been in the past, when we're planning for this, and that's a big concern for me, is I wouldn't want to, choose that and then not have the option to do the sessions that I feel I need to have. Also, how would you choose that if the 3 or 4 people express interest? How is it determined which 2 that are allowed to go, and who makes that determination?
Definitely speak internally about that. I'm not sure what the process will be for JLMBC members, but we do have a procedure for staff. But we haven't discussed yet what the motion would be for JLMBC members, but we'll definitely take everyone's interest into consideration.
That would be a big concern for me, because then if we're authorizing something, but then we have no input into how that determination is made, that's a big concern for me.
Understood.
Do funds exist to help more JLMBC members go if they wanted to go?
I don't think I would be the right person to ask for that. I don't oversee the employee benefits trust
Penny,
fund.
we'll need to talk, take a look at our budget, see how much it is, budgeted there, and whether there's sufficient funds for more than, 2, JLMBC members to attend.
But then am I correct in understanding that there is funding for us to go to 2 conferences? Because it doesn't seem like there's a limit, that there could be people going to the, I'm not gonna try to pronounce it again, the first one, and then also this one. I didn't see any limitation to that. So if somebody was going to both conferences, that would be an additional expense
I
as
think
well.
depending upon how much interest we get for stock, whether we would have to limit it. It is a new conference for us. So if it is approved, we'll need to see the level of interest and how much funding we have to account for, attendees for both conference. I'm not familiar with what our current travel budget is. I would need to discuss that with Paul. But yes, I mean, we would need to take into account how much money was, how much funds was budgeted for both, and then whether we can accommodate, all of the JLMBC members and staff who would be interested in going.
And I do see Paul's hand is up on the Zoom.
Hey, good morning, everyone. So there is enough money in the budget for any JLMBC members to go. It has been a past practice for us to not have many staff go to this particular location just because of the tourist aspect of it and the higher cost of travel. So we could entertain, or if the JLMBC wanted to entertain a motion for all JLMBC members to go, and just keep the staff in person capped. That would be another option to consider.
Thanks, Paul.
Would it be prudent to table this item until next meeting to gauge the interest of the JLMBC members? The discussion may be moot if only one of us has an interest in attending the conference. On the other hand, if 3 or more people show an interest, then we can pick this up once staff determines precisely how many people can be accommodated in their budget.
When is the early bird out?
It's not for a few months, so we have plenty of time.
Well, the deadline to
Well-
respond to staff is March 27th.
Yeah.
Our next meeting is the week after. But I can tell you, I have no interest in going because I don't have time. So there's one down, same down. I can speak to these 2 gentlemen here. So you've got 4 out of the 10 who aren't going. Look at your schedules, think about it. We'll pick this up at the next meeting.
And I could also extend the deadline to respond, so until the next meeting.
I don't think this 27th is unreasonable, and that's
Okay.
prior to our next meeting. We can pick this up at the next meeting.
Oh, okay.
And by that time, you'll make a determination about the precise amount of money that you have to spend. You'll have an indication from the other 6 members on their interest in attending. We can accommodate people who can accommodate. Point is, we don't have to make a decision yet.
Yeah, so do it kind of the other way, okay. But part of me was, a little hesitant because then it establishes a new benchmark for what we do going forward. But if we're doing it, if we're flipping the order of things and asking for, interest first, and then
Before-
coming back
right,
and then
before we authorize.
approving those interested,
Correct.
I like that. How does everybody else feel about that?
I'm good with that. I mean, the motion has, I think, a couple. Andy? Would you table the entire thing?
I move that we continue this item until the next meeting, sufficient to allow staff to gauge interest from JLMBC members and to determine the amount of money that they have to send as many people as, or sorry. Okay.
Sounds good.
Okay, so just to clarify, this is the motion to table the IFEVP report till the next meeting.
Yeah, and to have, staff reach out, still do that email to reach out, and then we'll know, and then we can approve a particular, group of people, and we'll know going into it.
Thank you. So we will start roll call, starting first. Sorry, was there a second?
Yeah,
Ms. Palombi.
So we'll start with roll call, starting first with the employee organizations and then management. Shauna Janeway,
I,
Marlene Fonseca,
Aye.
Lisa Palombi,
Aye.
Tony Royster.
Aye.
Matthew Crawford,
Aye.
Paul Gerard,
Aye.
Hetty Santos. The vote is unanimous. The motion passes.
thank you.
Pleasure.
Okay, so moving on to informational items, benefit provider presentation from Anthem on the Blue Vision.
Morning. I'm Terry Graff from Keenan, and I just want to introduce the Blue Vision overview from Anthem this morning. The city moved to Blue Vision in 2024, the beginning of 2024. Prior to that, it was with IMED for 6 years, and IMED was using the same, or the Blue Vision is using the same network as IMED, so there was no disruption in terms of providers during that time. So this is the first time that we've seen any of the utilization from 2024. So Blueview is going to talk about the network utilization, exam and materials utilization, the cost of frames, and the lens enhancement options. And one of the things just to point out is that this does not include some of the members that are going to Kaiser to get their eye exams. So we did put that number in there so that you have a full picture of the vision utilization. I'll turn it over to
Thanks, Terry.
Anthem.
Hi, Amy Wassam with Anthem, and I've been with them for almost 20 years now, so doing Blueview Vision. And one of the nice things I can report today is because of the consistency of the network, the numbers are very, very consistent from what they were in the previous 2023 year. The only significant difference I see at all is you adopted the Plus plan in 2023, and I see utilization growing in the Plus plan, which we'll get to towards the end. And then a few comments around your pop-up clinics where we've made some improvements in communication with the employees that are attending. So we have more utilized appointments of your pop-up clinics. But other than that, your utilization is very, very steady and consistent with prior years. So just in summary, we do cover the total population, including the Kaiser. So we have over 55,478 members on the average for the year. We have 95.9% in-network utilization. So really your members are finding the providers that they need in the network and able to maximize their benefits by going in network. Savings that are in a vision plan There's discounts when you buy above your frame purchase, the lens enhancement options that we're going to talk about. Those are at a fixed cost to your member. So again, more savings for them. And then we have a 24.8% exam utilization, which is really pretty standard for the industry. Everybody would think everybody goes for an eye exam every year. But actually it's about every 3 years that people go for an eye exam, even when they have one covered. So very standard for the industry as well. When we move on to the membership summary, I'm going to work on the slide for next year because it makes it look like you had a lot of change, but really, if you look at the numbers over on the left, it's very little change. So it's very consistent. It's just the way this this graph worked out, and I'll work to improve that in the future. It's up a little bit over 2023, but very consistent again with your membership. Yeah, subscribers. So you have your total members, you have your dependents, and the subscribers would be the actual employees themselves. I could make that change to say employees instead. It's what we use in our world, but maybe not so familiar for everybody else. So I'll make that change as well. The network utilization, when we look at the graph over on the left, it's all the dollars that were spent on your plan. 30.7% were spent at an independent and 65.2% spent at a retail location. We have that vast diversity in our network that encompasses a lot of marquee retail networks, but also regional retail locations as well. So a lot of choices for your members. And consistent really with last year, it's up a little bit. You have a 55% utilization at Plus providers. So your members are definitely taking advantage of that. And as I mentioned, the 95.9 in network utilization, the benchmark is 97. So you're about 1% off of that. But people like to go many different places depending on what their preferences are, especially to purchase their eyeglasses. They'll stay in network a little bit more for exams sometimes, but then, you know, choose to go someplace else possibly for an eyeglass. So when we dive a little bit deeper into where they're going, you'll see the top bar is the independent providers, 30%, both for exams and materials are going to independents. And this graph, the way our data lays out, lens crafters, and if you look at the very bottom, Eye Exam of California, because of specific legislation in California, the eye doctor has to be separate from the actual retail location. So really you have to add those numbers together to get a good picture of who's going to lens crafters. So it's about, for eye exams, 34% going to a lens crafters, and for materials about 29.2%. So very comparable with who's going to an independent. And all the lens crafters are the Plus providers as well. So probably drawing a lot of attention of your members going to lens crafters. The next biggest number really is Target on there, and then it just kind of spreads out from there. The nice thing with the diversity of our network also and having those retailers is they're open in the evenings and on the weekends, so people don't have to take time off of work. So you'll also see that 22.1% was weekend utilization. So really giving people those options. If we turn and look at the financial summary, if I look at the box up to the upper right, you'll see that the total spend was 2.6 million on vision services, that's eye exams and materials, with the average claimant amount per claim of $159. Some people might get an exam, not get materials. They might wait or not be eligible for something at that time. So it's not 150 or 200 plus an eye exam. That's the average claimant amount. Then you'll see over to the left there, the Blueview Vision exams at the 24.8. And we've added in the non-Blueview Vision exams, which would be the Kaiser You also could have exams coming through your medical when people have medical conditions and the eye doctor's doing more tests or concerned about more things about that patient. They might be billing to medical with, conditions like diabetes or cardiac, anything that has to do with your cardiovascular system can affect your eyesight significantly. So that there'll be claims in your medical as well. So it would definitely be higher than the 31.2 that we have for just what we consider the routine eye exams or your annual eye exams. You'll see cost-wise that the eyewear, which is eyeglasses and lenses, equates to 73% of the spend, which again is very standard for the industry, and contacts down at 27%. We've also broken down the frame so you can see how your members are purchasing. So you will see a lot of buckets over here. So I just wanted to try and summarize. Your benefit covers frames at $150. So everything that was up to $150 is 24% of your utilization. So a lot of people are purchasing within that 150. Then if they go to a plus provider, they get the additional $50. So that'd be $200. So the next bucket I kind of, rounded out was the 170 to 200, and 55% of your members are staying within that area. I would say in the industry, people are still standard at 130. They're pushing up to the 150, and a few clients are starting to push up a little bit above that if they're on a voluntary basis, meaning the employees are paying for it, because people do like the style of whatever glasses, frames that they want to pick out. But I would say, for the industry, you're at a very great position at the 150 for your standard benefit, and having the plus benefit up to 100 to 200.
May I ask, what's kind of the landscape for glasses at this moment? It has inflation hit that? I haven't bought glasses in a little bit, but is there, has inflation hit that like it's hit everything else? Like, what is kind of the average frame cost at this point?
I don't have the average frame cost on here for you right now. I mean, we could kind of pick it out from where your members are actually purchasing. Thank you, Richard, for writing that down for me. In the vision industry, we stuck to like a 3% trend year over year. I haven't seen that change much. Our actuaries are definitely always looking at our block of business and staying competitive. And with that, all of our providers are required to carry 100 frames or more of $130 or less, so that members have the choice. So whether a frame costs have gone up significantly, I'm sure designer styles and that type of thing probably have, but I'll get you a better answer to that.
Thank you, I appreciate that. I was just trying to understand if it's that people are, I'm looking specifically like at the above $200 and trying to understand if that's having to or
Definitely not
choosing to.
choosing to.
Okay.
People are really into their styles. I've got some Pradas here that, I can't get these at America's Best or Target, but I can get them at a Lens Crafters or a Pearl, or maybe at a private, an independent doctor. So it's really choice. There's plenty of choice under the 150 even, so.
The landscape may be changing with some tariffs if they do go through, so we'll get a better understanding of what to anticipate before that.
Yeah.
Thank you, appreciate it.
Yeah. I like new questions. I've been doing this a long time, and it's always great when I get a new one that I don't have the exact answer to. So thank you. Lens enhancements. This is the part that I don't think a lot of people think about. You get your eyeglasses and you don't think that there's something in addition to that base lens, whether it be a single, a bifocal, a trifocal, or a progressive, that it might be in there. So there's lots of add-ons that can come. And so our benefit makeup makes it so that those are at a fixed cost for the most popular ones, or they're 20% off. So really bringing member savings in that area. You'll see that the anti-reflective is, one of the most popular lens options at a 22%. And a lot of these lens options have more than one feature. So anti-reflective means I can't see myself in your eyeglass lenses when I look at you. So it's not reflecting what the people are seeing. It also cuts down on glare on computers. It has blue light properties to it. So it does a lot more than just the one thing, which a lot of lens enhancements do. So you'll see the average member out of pocket for that is $82. Polycarbonate is a safer technology of a lens instead of a plastic or a glass. So if for some reason you had an impact, it wouldn't hopefully damage your eyes. High index is when people have a very strong prescription and your lens might get very thick to hold that prescription. It makes it so they can do it thinner. So you have a small percentage of the high index, but it's also part of our discount program. And then you'll see the rest of them on there as well. So just giving you an idea of how people are purchasing those lens enhancements that we have. And then finally, we'll come just to the highlights and then we'll answer any additional questions that you have. So the plus provider utilization I told you is up. So last year it was 48%, now it's 55 for exams, and then for frames it was 53, and now it's 60%. So you're into your third year of plus going into this year. So you had 23, 24, this will be your third year. And members are really utilizing that benefit to get the $0 eye exam and the additional $50 towards their frame. We supported 4 on-site clinics for the city, and we extended a day at each one. So you'll see in 23, we had available appointments of 288, and then in 2024, we had 342. So we have more available appointments for your members, as well as the on-site person for those clinics is trying to text and remind people that they have their appointments, because what was happening, we were having appointments that people just weren't showing up for. And so a lot of people wanted the appointments. It fills up really quickly and then people don't show up. And it's a little bit of a frustrating situation. So we're really trying to make sure that everybody that signs up utilizes those appointments, or we go to the wait list and we start to notify other people to make sure we're utilizing. And we will be doing 4 again this year for the city.
At those appointments, you're not getting glasses, right? It's just the exam.
No, it's the exam, and they have a selection of glasses, and you can order contacts. So it's full service. It's usually a local lens crafters or Target that would support. And they bring their doctor as well as a staff person to help with the sign-in and the insurance and all that type of thing, and an optician that would help you pick and select your glasses and your lenses that you want.
Remind us of what the criteria is for the businesses to be plus members.
There's quite a few criteria, actually. They have to have online scheduling. Richard, can you write that one down too? Because plus is still new to me as of last year. But I think there's about 8 different criteria for a provider to be a plus provider. So we do have a number of independent providers that are plus, and then the larger retail locations such as Lens Crafters and Target. But I will get you the specifics of what it is to be a plus provider.
On the same topic of plus providers, so I'm not a current city employee, so I'm not like you. I know we heard about this at one point, but I'd like my members to be able to take advantage of it and to be sure that they're aware of it. So is there, I mean, is it just in the package they get in October, or are there reminders that if they use their plus provider or a plus provider vendor that they get this additional benefit?
That is a great segue to the communications.
Okay, and then so before we
Yeah, so I
move into
mean,
that, then
we did do 3 customized communications last year, and we could look at a plus one. Your utilization is up in plus, so
yeah,
there's quite a few people that are utilizing it. On our provider finder, there is a plus designation. So whether you're at anthem.com or you're on Sydney, and you can filter on and off for plus providers as well. So I would say most of your membership would probably be seeing it if they're looking for a provider on Find Care or on Sydney. But definitely when we're working with Paul, we can see if, that would rate to the top of a communication for this next year to work on.
It's also called out on their benefit summary. they'll see the differential between a regular provider and a plus provider. And I think that's really what's driving the members to plus provider.
On their benefit summary, like, do they have a portal that they can log in and see the?
Yeah, there's a PDF available, and then there's a benefit portal where they call out the differential.
And I have an example here if you want to look
I
at it.
would, because
Okay.
I would like to include
I
at
will.
least a little
Yeah,
blurb
color
in my
version.
communication.
You've got a color version? I don't have a color printer.
And
No.
I want to be sure the information.
Yeah,
Last question is the pop-up. Do you bring that plus provider to the pop-up?
yes, yes, they
Okay.
are. So it's usually supported by lens crafters or a Target. So yes, those would be plus providers. So they're not generally supported by an independent provider.
Thank you. Is it 3 pages or am I possible? Thank you.
Where they held here or in medical services?
You have 4 different locations that your pop-up clinics are held in that were predetermined. And so we held them in the exact same locations last year, and I think the plan is for this next year as well.
Correct. We partner with Brianna on the benefits team to determine the location. And there may be some variances year over year, depending on where the highest need is.
Sorry, just to jump in, Penny, those locations we decide where those locations are going to be held as part of our open enrollment, workshops and, and the benefits, services, that we provide, during and in the run up to open enrollment.
Any additional questions?
Did you say you would get us the criteria?
I will, yeah.
Yeah, and we'll get you an electronic version of the benefit summary. So if you want to help us distribute it, we would be greatly appreciative of it.
It's in the top 2 buckets that you see the plus information in the exam and then in the frame right below it.
I don't see the word plus jumping out at me anywhere, but I will read it.
Okay, well, let us know if you have any questions in the future.
Thank you so much.
Thank you for your time.
Michael R, the education presentation, benchmarking, and then after that, the underwriting.
Hello, Gordon Darm with Enon. Benchmark presentation is number 2. So we were here about a month ago, looking to present the benchmarking, and there were some questions regarding some of the information. We've since clarified those. The information was not incorrect. It was an average taken over many plans that averaged out to 15, where with Shauna's assistance, we were able to, we've laid them out this time where about a $10 copays and a lot of $20 copays. You add those together and kind of end up with a 15. So that was somewhat misleading, and we've corrected for that. So thank you. I'm just going to go over some highlights of benchmarks between plans. I think on the first page, if you look, there's a significant difference between Southern California and Northern California. Statewide, you blend the 2 together and it's a third complete different scenario. So it's more important that we really focus on SoCal and understand what's going on in Northern California as well too. Southern California predominantly dominated by HMOs, whereas in Northern California, you see 25% HMOs. Here you have 84%. And you do have other options, HMO, high deductible health plans, PPOs, and also EPOs. EPOs are pretty much equivalent to HMOs, but because the HMO network is not as expanded in Northern California, it's an HMO plan design utilizing a PPO network. There's still no out-of-network benefits. It's all in-network only, just like an HMO. But they use EPO so that they can bring an HMO type of design to more rural areas where there's no HMO networks. I think if you look SoCal, down at the bottom right corner, PPO high deductible health plans, you're not even registering there yet. And there's a couple of drivers there. One is the access to lower costing healthcare than Northern California. And so the need to necessarily go there isn't as great. And then I think there is the concern relative to high deductible health plans typically are lower in cost, but they shift a significant burden at the time to the claimants. So while employees may love the lower employee contribution requirement, when they actually need the services, they're gonna have a higher deductible that they need to meet. And that's oftentimes been resisted by bargaining and by management as well too. And the biggest concern there is that would a plan like that eventually become the standard? And now we've moved from a more comprehensive coverage to a high deductible type of coverage.
So,
Yeah.
I thank you for making the change, I appreciate it. For NorCal, for the big difference, is it, you mentioned rural, is that really kind of the driver for that?
Yeah, absolutely.
I was curious about that.
Yeah, it's several things. Northern California basically comprises the Bakersfield line and above. And so you have 2/3 of the landmass covering 1/3 of the population. And so that population is spread out significantly outside of arguably the San Francisco Bay Area, Sacramento, maybe Fresno. Those are pretty much your major hubs in Northern California. And so there's a need to, and I've actually moved people into EPO plan, different public entities into EPO plans and so forth, just so that they can have an HMO-like benefit, but they're not getting as strong of a discount because that's usually the difference between the HMO and the PPO is the cost savings are not going to be as substantial. Okay, I'll move on to the next slide. We kind of talked about high deductible health plans, and you can see how they're slow to enter in. I do believe there will be a trend going forward, and it's basically as our younger population takes over our jobs, and because they are as your population moves to a younger workforce, they are more tech savvy. They almost prefer a virtual visit to going into the office, and they want to handle everything on their phone. And plus, they look at the advantage. They're young, and typically high deductible health plans, if they qualify, have a health savings account attached to them. That health savings account can be substantial when you're younger because one, the ACA made it so that, first of all, your preventive wellness checkup and so forth is covered at 100%, even on a high deductible health plan. And outside of that, the younger population says, I'm really not going to need the plan. So it's a good fit for me. And I can take money, put it in a health savings account, and imagine over 20 years, the amount of balance that you could put into that type of an account. So it is a strategy. It's something that I know the city should be considering going forward as you look at your workforce base. Are you in that area where your workforce age is actually going down? It's always a nice thing when we get younger 1 year later. And when that happens, you might want to be thinking of having the right type of a plan that they can use as well too. But as of right now, it's within the public entities. You can see the counties that do have them and other public entities that have them.
They offer them as one of the options.
Yes. Yeah, there's one, I think, in here that shows City of Anaheim, a Blue Shield high deductible health plan only. And
That's if you opt into Blue Shield, so there's other providers.
I'm not sure exactly what the benchmark of what, if they offer other plans or not. I'll come back with that information.
I think you're correct. There are multiple options available to City of Anaheim. Blue Shield is one of them.
Okay, fair enough. Thank you. Thanks, Lee. And then on the HMO office visit copays, that's what the OV stands for. You can see that it's within the range is pretty much $10 to $20. There are a few that have some higher co-payments as well too. 15 being kind of the average standard for CalPERS, and 20 being the most prevalent for non-CalPERS plans. And we have all those nice County of Los Angeles plans
Lots of
listed.
options.
Lots of options, that's right.
I'm surprised to see Orange County has a $5.
Yeah,
No network.
yeah.
Oh, that was it, okay, I was
Yeah.
wondering.
And that's another thing, well, similar to what the city does as well too. Narrowed networks, either you can afford a lower co-payment at the same price, or you offer the same benefit as your other plans, but it's still at a reduced cost as well too, because the discounts are better. And then on the PPO side, which you don't have a lot of PPO enrollment, deductibles and so forth, you're currently at $750, $1,500 for family in network, and we hope they never need to use the out of network deductibles. The RFP that we put out requested 1,000, 2,000 as well too, and you can kind of see there the ranges that we have. Relative to prescription drug co-payments, the city currently has $10 generic, $20 brand, and $40 specialty. The RFP went out with a 10, 30, 50, and you can kind of see the ranges there on 3 tiers for generic brand and non-formulary brand. Any questions on that? Are there any benchmarks that you'd like to see going forward? Any different ones? We'll keep you informed as we go through, especially last night, the RFPs were all due back to us. So we have a lot of data right now, so we'll see how they responded relative to pricing benchmarks and so forth.
That's an unanswerable question. If we were to go with the high deductible plan, when it came time to pricing, if, as you say, the most likely consumers for the high deductible are the younger, more able-bodied, I'm never gonna get sick, person. So if those people are moved out of the pool that's being assessed for the cost for the regular plan, is that gonna drive the cost of those plans way up because the young, healthy people who are averaging out are?
Yeah. A lot of it's going to depend on how the carrier does the underwriting. So the first assumption would be that the high deductible health plan would be with the same carrier that the other plans are with. If you pull it out, definitely that plan's going to go down, the others are going to go up. There's no choice because there's no commingling of risk. If the high deductible health plan were to stay with the complete with that one carrier, then it really depends on how is that carrier going to underwrite renewals and so forth. Are they going to figure out what's needed for all the plans combined and pass on one common renewal for everybody? Are they going to do that at a certain credibility level and say some of the plans are going to be higher based off experience because they're the loss leaders, and so we're going to increase them a little bit? It all depends. So both could happen, and it's typically us working with, well, getting direction from you, what your preference is, and then working with the carriers to see that that's the approach. When it's all said and done, what the carriers want is it's not about, no, I need this amount of money for this slice of pie. They want to know, they want to make sure that they get the money for the whole pie. And so from that perspective, there's some flexibility there. Does that help? Thank you.
To be clear, that the discussion around the high deductibles and impact on the rest of the boards just kind of coming up with nothing at this point, right? Because we don't have anybody in them right
We-
now, and we're not hiring anybody, so
Yeah,
I mean, I can't imagine we're gonna have a big flood of people that currently have the plans that are offered now that decide to move. That's,
Yeah.
it would be a weird way to go, that
Yeah.
your healthcare is free enough, so.
we did ask for a high deductible health plan proposal in the RFP process. There's no obligation on the city's part, but it's going to be interesting, and I think it's something that as we move forward, even in renewals, we might want to say, hey, how would this be priced? And the carriers typically give us, this is how it's priced, and this is what our enrollment assumption is relative to it. That and it's not going to be a huge percentage. It's going to be, 5%. I can't imagine more than 10% looking to move over into that.
Thank you.
Thank you.
I'm assuming you're gonna roll into the next one.
Yeah. Actually, I'll let John introduce himself.
Hello, everybody. Good morning. My name is John. I'm also from Keenan. Today, I'm going to give you a big high overview of Underwriting 101. So currently, right now, City of LA, they have their plans on a fully insured basis. So when we go to page 3, the difference between the fully insured and the self-insured. Fully insured, the client or City of LA, they pay just the premiums. All the risk is back on the carrier side. So they take care of all the healthcare costs. They implement all the California mandates and they set payment schedules. Okay. The employer, again, pays just a fixed premium and everything else is covered by the insurer carrier itself. Compared to the self-insured side, where actually the employer, City of LA, takes all the risk. So they're responsible for paying the claims as it incurs. They take they have more control over the plan so they can they can see what their cash flow is at the end of the day, because you're not paying the full premium itself. Just the large claims going forward. And you can see by doing that, you can if there's not a lot of claims per month, then the city will actually save money by having that excess money in your bank accounts. Okay.
Typically, if the city wanted to entertain self-funding, we would look to the dental and vision program first to kind of dip your toes in and see how you like the temperature of the water before we made recommendations relative to the medical program.
Next page. So there's only 2 options for employer groups to go to. It's either in small group or in large group. So in this case, cities in large group, but as a small group, they're typically a small group when they're under 100 employees. It's community rated by class or CRC, which is also known as manual rating. It's adjusted, the community rates are adjusted by the age, the sex, the state where the employee lives in, the area that they live in, the city, and also the industry. So on the industry, they're comparing a Walmart store manager compared to someone that works in construction. Someone that works in construction is a higher risk compared to a Walmart store manager. So that's how it gets adjusted. And then also they either provide tiers on a 4-tier rates or on an age banded basis. Compared to the large group size, it's over 100 employees. It's either experience or community rated by class, or also known as manuals. There's no pre-existing conditions. And because this is over 100 employees, you're going to have experience. So depending on the size of group, it's either going to be blended with experience it's blended with your experience and credibility.
Currently, both for the city, Anthem plans are 100% experience rated, So there's no community rating involved. And then also, yeah, the same is true on the Kaiser side as well.
Next page.
Before we move on, I'm sorry,
Yeah.
could you just explain community rating?
Sure, community rating is their base rate set by actuary. So the way it's blended is that it takes your employees, depending on where they live, and the rates itself is based off the provider cost. So it's a weighted average of your employee plus the providers that they're assigned to, or the doctors that are assigned to.
A carrier basically takes their pooled book of business and says, I'm gonna adjust it for their geographic location, their gender profile, their age factor, and their industry. And from the, and there, they're gonna get what's community rated basis. So in other words, you can have a wellness program and everybody's in it and they're all doing great. It's not gonna help you because it's community rated.
The actual claim cost, right? Claim cost.
Well, more and more large claimants. And the other thing, the trends that are developing, which in particular, one of the trends right now that we're watching closely is on the prescription drug side, GLP-1 usage, the Wegovys and the other weight loss medications, and well, they're treating more than just that, but those type of events.
So on page 5, starting off with claims. So a claim is actually a healthcare expense. So like if you go to the doctors and you're seeing the doctor yourself, that's actually a claim. So the way they track that is, when you go to the doctors, they actually pay for that and it goes into the system. So there's 2 ways of classifying what a claim is. First way, the more preferable way is called capitation. So with capitation, the carrier actually pays the provider a flat dollar amount per month per employee, per member, no matter if they use the doctors or not. It's a flat dollar amount that they pay, and the carrier is telling the doctors, we're going to give you this money each month. We're going to have you be responsible for taking care or managing the health care of that member itself. Compared to the other way, which is fee for service. Fee for service is when you go to the doctors, actually the actual cost of seeing the doctor is actually put into the system, and that's the kind of claim that's called fee for service. It's paid directly.
The one exception to that is the Kaiser model. Kaiser's a budget-based model, also known as a staff model. All of their providers are, well, typically are Kaiser employees. So when you go to the doctor's office in a Kaiser situation, there's no dollars that are exchanged from Kaiser, the insurance carrier, to Kaiser, the provider, relative to a claim cost. However, that office visit is assigned a claim dollar value so that the underwriting is somewhat consistent with the other model as well too.
Pulling point. An example of a pulling point is about 200,000, and that's based off the rating. Any claim that's below the pulling point is included into the renewal. Anything that's over the pulling point is forgiven by the carrier. The carrier actually eats the cost. So for example, if you have a claim that's 350,000 and your pulling point is 200,000, your renewal will include up to 200,000, and the excess of the 200,000 is forgiven by the carrier, which will be in the form of a credit back to you. Okay. To cover this, there's a pulling charge with that. So the pulling charge is a charge that is covered up to the pulling point, which is 200,000 as an example. Go ahead, Andy.
Yeah, just we have 2 different pooling strategies relative to your 2 carriers. Anthem and Kaiser. On the Anthem side, we have I believe it's in the $300,000 range pooling point. Meaning if a claimant has a high cost claim and it's above 300,000 or any, and it's not just a high cost claim, it's for the entire year, for the plan year. If it goes above 300,000, that point, the amounts above 300,000 don't count towards the claim experience. That they are basically are paid through the pool charge that's being charged. On the Kaiser side, we're at a 900,000. I believe it's either 875 or I think we moved to 900,000 this year. So there's a big difference, but as you can imagine, we pay a lot more $100,000 pooling charge than we do for a 900,000 pooling charge, because up to 900,000 is attributed to the health plan, and any amounts above that. So you're really talking about almost how many $1 million claims are you going to have with Kaiser? And that's something that we get very intimate with every renewal season with both carriers relative to, is the pool charge and the pooling correctly allocated?
Is that something, for those points and the charges, things that they put into the RFP and we use to judge the RFP, or is that something that's negotiated as we're finalizing contracts?
We should have full disclosure because we asked for the underwriting models. So we should see what they're using. And then part of that will be that process where we will meet with them and discuss it. And it's typically only done when we get close to them being finalists.
Is it a percentage or is it like a flat?
Some carriers do it as a percentage and others do it as a flat PMPM, per member per month.
Over a 3-year period, it's one of those where, 1 year the plan wins. We had way more high cost claimants than we paid for pooling, and everybody goes hooray. And then the next year we're below that, and then the third year we kind of even out. So over 3 years it typically kind of evens out. And the idea is not to take advantage necessarily of pool charges. It's just a way of managing high cost relative to that.
And lastly, you'll see some.
Sorry, I just wondering, want to come up for Kaiser, they typically set that pooling level based on your membership. And so as the city's membership continues to grow, I think you're at 60 to 65% of total membership with Kaiser as opposed to Anthem. That's why that threshold has gotten so high. So in essence, they're dictating what that threshold should be for your pooling point, takes us up to 900,000. So both Siegel and Keon have discussed with Kaiser opportunities to set that based on the city's risk tolerance. So if the threshold came down from 900 to 500,000, as an example, that may be possible, but they would also adjust their pooling charge. So it will be a balance between the two, but that is the whole reason I think we struggle with Kaiser's pooling level, is that just because your membership continues to rise, doesn't mean your risk tolerance is at the same pace. So then that's a genuine concern that both organizations have.
Thank you.
I think the other point with Kaiser too is each year it typically is going up, I think either $25,000 or $50,000, where we've seen the Anthem one remain kind of flat. And the reason given is just to adjust for trend and for inflation and utilization costs and so forth. Yeah, and it's always a struggle to reach common ground on that area. Which leads us into trend. So year over year, trend is basically two factors. It's the inflation within healthcare, and it's changes in the utilization within healthcare. In other words, people using more services and so forth. And the two combined equate to trend. So we have trend on both the fee-for-service claims, and we also have trend on capitation. In other words, the capitation fees that are paid to the providers and paid to the hospitals, they will also increase year over year, and they have their schedule. So within the renewal, we see increases in capitation as well too. 4 to 8% on the annual capitation trend is what we typically see. I try to keep it under that level. And on the fee for service, right now, and this is kind of, you've seen the last renewals, and it's kind of reflected in there that trend is higher between a 9 and 13%. The highest trend right now that we have is what we're seeing in prescription drugs. There's a lot of high cost drugs coming to the market. They're being utilized by the membership. And so they're usually in the 12 to 14% range. Now, these are annual trends, but if you can imagine, as we prepare for the 2026 rates, we're looking at 2024 experience. So you're adding almost 2 years of trend to that. So it has a compounding effect such that we're not going to see the trend, what's called the trend factor, go up by 4 to 8%. It's much higher than that because it goes up by the number of months from the one plan to the next, to the what you're projecting. Very similar to how compound interest works and so forth. To look at it going forward. Okay. And then credibility is also a component. Again, we talked about credibility a little bit, and basically, how credible is the plan's experience depends on, there might be a blending of a community rate with the experience rate. And so because of that, you guys are 100% based off your experience, so there is no credibility blending with manuals. You want to go over retention, or you want me to?
Yeah, go ahead.
Okay, and then finally, we've only talked about really so far, how do we pay for services used by the members? Well, there's a cost for administration for all that. And it's not just for processing claims, it's the customer service, it's confirming eligibility and so forth. All those come into the retention administration buckets. It's not uncommon to also have commissions built into rates. I will tell you this, we have 0 commissions built into your rates. So it is a component for other plans. It's not for you. Well, it is a component for you, but it's 0. And then any premium taxes that might be allocated by the state, or even now we have like quarry taxes at times and so forth. In addition to that, there's sometimes what we also see is margin included. Margin is basically, we want to make sure that the carrier wants to make sure that they have a high confidence level that the claim, that the premium they're collecting will cover the claim cost. And so they do the trend adjustment of the claim experience to project what it's going to be. And then they might say, I need a 1 or 2% margin on top of that, just to make sure that I'm covered. And that's usually, it's usually calculated by actuaries who do the whole regression analysis and everything else and say, based off of this, we need this much margin to have a confidence level of 90, 95%. Maybe the loss ratio, yeah. And then the loss ratio, there's typically 2 loss ratios. There's a claim cost loss ratio and a total cost loss ratio. The claim cost just says, how much premium did I pay and how much was my claim cost? And you look at the difference, and hopefully it's around 85%. I usually don't go by that. I usually try to go by the total cost loss ratio, which includes all the retention, the administration, all your costs. So you go total cost to total premium. And typically, if it's 100%, well, you can pretty much assume that you're going to have a trend increase for the next year. If it's 90%, you might be able to hold your rates for the next year. So we're always trying to manage that total cost ratio downward, so that hopefully in the following year, your renewal impact isn't as significant. Okay, any questions? Yeah, okay. Next exhibit, this is just all the stuff we look at. Remember I told you about the numbers? Here's the numbers. And you can just, I'm just gonna tell you, it's like, so we look at, the rows going down are all different months. Going across in the columns, we have total membership subscribers. Again, the difference between subscribers, that's these are your employees who subscribe. Members, the easiest way I remember it, all the belly buttons covered under the plan. And then we look at the total premium cost. We look at the amounts paid for medical claims. We look at capitation. We look for pharmacy payments, and that's total payments. So that would be a claim cost ratio right there that comes out on the far right. Again, we'd have a couple of more rows in there for administration and so forth to make it a total cost report. And then remember, we had a lengthier discussion relative to pooling. Well, here's a large claim report that kind of shows you a plan having 11 large claimants above, what's the threshold, 250,000, and you see the amounts of the claim and the amount over such that if you add all those numbers up to where it says overpooling, 1.6 million would have not applied to the experience. It would apply to the pool charge and be taken out. And typically we look at, what's the diagnosis, what happened, and why do we care about that? Is it going to be an ongoing large claim year over year? Is it just an acute, wasn't that acute?
Catastrophic claim.
A catastrophic claim that happened one time and one and done. And oftentimes now what we're seeing in particular, the blend of medical and prescription drugs, especially as we look at cancer patients and so forth, that cost is going up and reaching those pooling levels, oftentimes becoming high cost claimants.
So from a structure standpoint, conceptually, is kind of the goal there to kind of set your pooling point so that at least most of your above pool stuff is one-offs and not like we're going to see this every year for the next decade.
Yeah.
For an individual.
So when the pooling point will be set with both taken into consideration. I will tell you this because, and this is why self-funding is sometimes a little bit more dangerous, because you don't have a pool charge, you have an independent reinsurer. And sometimes that reinsurer will say, hey, you know what? We're going to laser the next year that claimant, and we're not going to cover them for less than $1 million. So there's a bigger risk and exposure sometimes on that side. But in general, we are working, we typically go very painstakingly through all large claimants with the carriers relative to, is this an ongoing large claim? Is this a one-time episode? And then plus the pool charge itself is typically community-based, because where we can get close, we can't get exact relative to how many, neither John nor I can tell you how many large claims you're gonna have next year. It's just.
Lower volumes of lead.
Yeah. Yeah.
Especially when it comes to premium ratio, I know it's significantly higher than others. That's something that triggers that, or it's just random?
It's usually the large claimants.
Large payments?
Yeah, it can be, you'll have a great loss ratio one month and then you'll have a horrible the next. It typically is not inconsistency on the carrier part on paying claims. They're pretty good about getting it in, getting them out, and paying the claims. So large claims usually do get reviewed for accuracy and so forth. As you can imagine, if you're going to spend $1 million, you're going to want that plan scrutinized and so forth. And both Anthem and Kaiser do an excellent job in that area of scrutinizing those claims as well too, to make sure they're adjudicated correctly. But it's still, the claim needs to be paid. They'll take the amount above pooling off, but that amount still will be there up to the pooling point.
And going to your point, in June of 2024, you see the loss ratio at about 109% compared to July, which is like 89, 90. So the large claims hit in that month.
I was wondering if the 125 in 23, June of 23, it looks like.
Yeah.
May of 23.
And look at the following month, 83%.
Okay. All right. Ready for your underwriting test? All right. So we start off with what we call the experience period, which is the plan experience that we have. Typically for the city of LA, it's either we have data through January or February. So we take 1 year of experience. So from February, let's say it's February 24 to February 25. We take that data is taken by the carrier. And then we look at the experience period, which is 26. Okay. We adjust, take off, make sure we've properly adjudicated large claimants, the pooling amount. So we do that. We add the pool charge in there, so it's net to that. And then we say, okay, fine, let's we got to project forward that cost. So we take our trend assumption and develop our trend factor based on how many months. And if it's claims through February, that means we have to add 22 months of trend to get to our 2026 projection. So that then gets applied. We have basically a projected claim amount for next year. To that we then add all our loads for administration, for any taxes that might happen. There's no commissions for you guys, so that would be zero, but there's usually a commission line and so forth. And if there's any changes in plan design or historical plan designs, we adjust for all those things. So it reflects what you're going to be, the plan design that you're going to be purchasing as well too. And from there, we then have basically a total projected cost. We divide it out by the membership that you have, compare that to what your current premium is for that same membership, and the delta is the renewal in a nutshell. And that's what all this beautiful stuff on the right tells you. And there's a little bit about manual rating. That's again, if you're not credible, but you are. So we won't take a lot of time to go over that. And the rest is just kind of in-depth look at how we develop trend, which is invigorating. And then community rating underwriting as well too, which doesn't really apply to you. All right. John, you want to hand out the tests?
Sure.
Any other questions I can answer, or John or I can answer for underwriting? Okay, well.
Profit margins would fall under administration.
Yeah, any
Yes.
type of profit loads are usually added within the admin. And it's been interesting because that's kind of John's role as an underwriter is where is the profit load? Because it's not necessarily in there. And sometimes we have carriers that add 1% to trend. They say their trends once. And we say, you know what, that kind of looks like a very high trend. Is that really profit? So all those kind of things come into question as we try to work through these. I will say this, that both of our carrier partners are very good at underwriting. We do disagree, as has been demonstrated in the past when we've presented renewals and so forth. But both have told us, look, our factors are our factors and we have to stick by them. Oftentimes at the end, it's us working with them, trying to reach some basically concessions based off business decisions. Okay. All right. Anything else I can answer for you on underwriting? Or John? Thank you.
And to report 257 on LA Well and change update.
Thank you, Chana. I will be presenting this report and the next report as well, but before I jump into that, I just wanted to do a follow-up on a question that Petty had brought up during the Anthem Blue Vision presentation. So Petty, regarding your question, I think about where the clinics are held. So I just spoke with Brianna from our Liberal team. So they do coordinate, with the various departments, and there are some criteria that have to be met in order for a location to be suitable. So for instance, they do need the location must have a facility that's capable of hosting a clinic, plus all of the attendees. And then another criteria that they look at is whether that location has sufficient employees who will be able to fill the appointment slots, for the clinics that are going to be held. But they do look to switch it up, so to speak. So I think that, so for example, in April, they're looking at hosting a clinic at the Hyperion facility. Okay. Now, going back over to the LAL plan change. So this report provides an overview of the change items for the LAL program that were recommended to the JLMBC and adopted at the October meeting. So for most of the items that we have listed on here, there are no updates and no changes to report except for two items. So the first one is on page 2, which is the medical plan RFP. Since the last update, we have received 125 questions from interested proposers, regarding the RFP. The responses were provided via addendum to the RFP. And proposals were due on Tuesday, March 4th, just a few days ago. A preliminary report will be presented to the JLMBC at the next meeting, with full recommendation expected to be presented during the May meeting. Now, for our next update, this is regarding the dependent eligibility verification audit, or DEV, and that is on page 3. So for this item, staff had met with one of our consultants, Siegel, to discuss the DEV audit, to discuss planning, implementation, and other areas of concerns that we had going into the DEV. From that meeting, staff feels that an RFI may not be needed, and we may be able to jump directly to the RFP, provided that it's sufficiently developed to cover the needs and concerns that we have for the DEV audit. Now, in terms of timeline, staff is looking to start the main DEV audit in early 2026, but we're also looking to be in a position to communicate the DEV audit in advance to prepare employees ahead of time and allow them sufficient time to gather their documents. And that brings us to the end of this report on the LAL plan change update. Is there any questions that you have that I can answer?
I have questions on the DEV. So you would need to do an RFP for those services,
Correct.
but is there sufficient time to complete that and do whatever negotiations and everything in order to be able to do the audit itself in early next year? Like, so that's less than a year.
We're cautiously optimistic that we're able to do it in time to go through the RFP in time and to complete negotiations in time to start the DEV in early 2026. Okay. I think, at least from my perspective, the RFP for the DEV should be a little bit more straightforward than some of the other RFPs that we have ongoing. So that is part of the that's why we're cautiously optimistic that we'll be able to meet this timeline.
Yeah, okay, that's a little more streamlined.
I'll just-
Thank you.
Yeah.
Our thoughts are consistent, I think, as Steve Murphy with Siegel Consulting. Long way down the microphone. In terms of the DEV audit, as Chung pointed out, I think we have enough time to do that. We've already begun the process of developing the RFP and the questionnaire, which will be reviewed by staff, I think, next week. We'll be able to get that out. I think our long-term plan is to help staff get through the evaluation process, select the appropriate vendor, but try to dovetail that into the communications work for open enrollment, so that it's out there in front. People are seeing what will be required once we get to kind of first quarter of 2026, when the actual work will be begun. And I think there's some hope or anticipation that people may proactively choose to remove dependents that may not be eligible in order to kind of avoid that audit process once it begins in Q1 of 2026. So that's kind of the stepped out approach that we've got, but I think we're very optimistic that we're going to meet those deadlines and be able to have us ready to go by Q1 of 2026. Sorry, Sean.
Thank you.
The other, I know this is really a question, but my concern also with, that timeline is that if it's the communication piece of it. So if that's being communicated during, annual enrollment, which makes sense, like I get the thinking behind that, and that definitely makes sense. If there are any other plan design changes or any other plan changes that come about as a result of the medical RFP, then that's a lot of things to communicate. We're adding more things to communicate. And so I certainly have some concerns about making sure that we are able to communicate everything. You know, I know I'll just speak generally for myself and, you know, probably for a lot of other people. The more things that you put on a list to remember, the fewer of those things you're gonna remember. At some point it gets to be overwhelming and you're not gonna get to the bottom of it. So it's a little bit of a concern.
Steve Murphy again, Siegel. I think we share those concerns. We've already begun discussions with city staff. We have another meeting scheduled for, I think, Tuesday of next week, because from an RFP perspective, we're not sure what the results are going to be, but we're anticipating there will be change. And so we're trying to get ahead of that curve as much as possible. Just saying, okay, if it all remains the same, we've gotten a great head start. If we're adding things or implementing, what type of tweaks would be made to the materials? Because materials have been fairly static for the last several years in order to kind of control costs and kind of manage the program effectively. So we understand those concerns and we're trying to anticipate as much as we can so we can get ahead of it. So I think the DIVA materials, probably be some notification of kind of what it is, what the anticipated requirements would be. Should be relatively small in the scheme of things, but the intent is to get out ahead of it so people understand this is going to happen. So if I'm going through enrollment, if I have a dependent like a divorced spouse that probably shouldn't be on, maybe I could proactively remove them before we get there. The intent is to kind of measure changes in dependent membership from like Q4 before to Q1. So we have a good sense of maybe how many did it proactively versus who went through the process and maybe what additional members may have been dropped. But regardless, the DIVA material should be relatively small, but direct to the point. And then we're really trying to anticipate what changes may occur as part of the RP process that we're going through right now. Should I go or should I stay?
What's the scope of the impact on the employee though? Are you asking everyone to validate the legitimacy of their dependent, or do you look at records? You go back and you see I have, you know, X number of children, I've given birth certificates, you have those on file, or someone scratched off that yeah, I saw the certificate. We don't have that, but he's good.
Yeah.
And that was 2 years ago. And so they possibly, you know, they're only 2 years old. It couldn't have been, they're not emancipated yet. So
I think in terms of kind of minimizing the impact to employees and their dependents, I think dependent children is, to your point, if I have a child, I have that child through 18 to 26 years old. That's a given. The bigger variability is going to be spouse. If I have changes in that could be an occurrence. I think the last audit was done in 2013.
The last audit, I think it was correct, was done in 2013. So we are overdue for a dev audit. And, you know, just to, just to go back to what Stephen has said about dependence, child dependent, like Stephen said, is that, you know, it's a more straightforward audit to just verify that they're still your child. But with spouses and domestic partners, that there's always the question as, okay, are they still your spouse? Are they still your domestic partner? We have had instances where members have divorced or terminated a domestic partnership but failed to notify the city. So part of the DEB is also to try to identify those instances and to correct those instances. And going back to the point that Paul had made about documents, Now, one of the nice things that we have with the new benefit system that was implemented in 2019 is that that system does have the ability to store documents. We did not have that ability with our old system. So, for employees who were adding dependents in 2019 and afterwards, we do have documents there that we can refer to and verify. Yes, we do have the birth certificate for this child. And so, we may not need to follow up with that employee for that child. But we may need to follow up if they have a spouse or a domestic partner on file, because we don't know whether that relationship is still valid.
But you're saying I need to go grab the 4 birth certificates I have in safe to show that my 4 kids are still my kids?
If, Stephen, I think that's wrong here, but if we,
I don't have any kids that were born after. So.
Good for you.
We have to.
Well, and by that same token, you said, are they still your spouse?
How do I
I
prove that?
I'm only aware of the marriage certificate that I was issued. I don't have an ongoing document that the government sends me that says, hey, you're still married.
I think the bigger question is, since that marriage, has there been a divorce? And I think that's the part we're trying to capture. So it's for 90% of the population, the records I've submitted are valid. Your marriage certificate, your birth certificates, that part's valid. I think what we're trying to, ascertain is using the timeline. So in 2013, you did one, but there wasn't any kind of process built in place from then to now to kind of monitor it and keep it. So it's almost like we're having to kind of start fresh from the beginning. So we're cognizant of the fact we're not trying to overburden participants for things we should have or should have access to. So I think as part of the evaluation process of vendors, we're trying to figure out what do they need, what can we draw from that will minimize impact, but still allow us to kind of vet where there are opportunities or questions about eligibility, so we can remove that. I think one of the things
But just the questions come from, I was trying to read Shauna's underlying concern, which is, this is not going to impact a lot of things, right?
it probably would be 5% or less of the covered population.
Meaning because that was a random sample of people, or because a lot of people you're gonna already have their records on hand?
Yeah, most of you have the records on hand, but you're choosing to validate it. I would say that the process going forward, we would go through this process, identify a partner that will help you do the DIVA. Right, for this moment in time, let's make 2026, it's done. But what will be the strategy going forward? So there's no
point.
Yeah.
You have a document management system that you require your employees to provide proof, and you maintain them.
Yeah, but even then, you would still want to do some sort of random sampling. It could be, you could do it, alphabetically, a third. You could do it by divisions or units and saying, well, we're each, it's just so it's structured, but it's done in a kind of non-biased way and consistent, so that we have this ongoing process. So it's like, we'll be able to maintain that. Because again, the advantage or disadvantage of the fact that you fully insure your coverage versus self-funding it. When you self-funding, you do one of these audits, you guess that the average claim per person is X. And if I take someone off, you project what those savings are. That's typically how it's done. Because you're fully insured, you're paying premium each month. That is tangible funds that go out for that covered dependent. It's oversimplifying. If I'm doing a family, maybe I have a dependent that should no longer be there, and that would have a financial impact to the city. So if they're removed, there are tangible savings. So there is value in doing this process. But I think importantly, it's like do it, but then find a way to maintain it, as opposed to kind of letting it get away and then saying, okay, now we have to do it again, because again, you have long-term employees. So I'll guarantee you, and we're all anticipating, it's like, I did this. Like, that was 2013. And, as we described or talked about the project, it's like, well, where were those records kept? And it's like, well, they were in boxes. Like, okay. So we're 10 plus years out and we're trying to figure out how we do that. So we have a better platform with TELUS. We'll be able to kind of capture that. But regardless, there will still be some need periodically to review those and just kind of reaffirm that that eligibility is still there. But the intent is not to overburden 95% of the population to find the savings from 5%.
Does it work for all the various programs that the subscriber can participate in? For instance, if you, like my spouse isn't covered by my regular insurance, but I have them on my eye insurance or dental or something. Once you do this audit, does it work for any other thing that you decide to add that spouse to, or do you have to continue to prove that to your spouse?
Ideally, you would do it kind of one fell swoop, which is across the continuum. If you're covering your family for dental and vision, but not medical, you would still go through the audit process to validate that. But that's going to be one of the variables that we're going to look at to kind of say, what's the most efficient way to get after this? And then how do we do it going forward? But very good point, because not everybody takes everything.
So basically, it's not, most people are not gonna have to pay attention to this at all. But there's gonna be outreach to particular.
What's gonna be
Is
done?
that what I
I think we're gonna figure out what the best approach is. So I think based on talking to the multiple vendors, we're gonna get ideas or strategies from them. And let's kind of figure out sometimes out. To be honest, you'll find an idea from a partner. You like the idea, but you don't like the partner, but you take that idea to the partner you do like and going, can we do this? And we'll try to find and navigate kind of the right approach. Because again, it's like, we want to kind of find where there's savings, because I think the savings that were found in the last cycle were significant for the investment of the audit itself. So it was a good return on investment. We'd expect the same thing, but if we do it right, we would see a decrease, and then we would just manage it going forward. It's just a matter of kind of those variables and questions that I think we want to balance, which is how much is too much engagement for the value of the return. So we'll want to strike that balance.
I have a couple questions. They're quick and they're easy.
You're really putting it on me now. It's gonna be easy.
Well, you just touched on one of my first ones. I was trying to think back to that audit and what the savings were. Do you remember what?
I don't, we weren't a part of it, but I think,
That's something I think we'll have to come back to, and respond later for you, Marlene. I was not part of that, dev audit at the time, so I don't recall the numbers offhand.
Okay. I have no more with the dev, but I have a question on the RFP. I can move on. Somebody else have dev? The RFP update, you reported that you had 125 questions from potential bidders. I just want to know if that number is high, is that a normal number? It seems high to me.
I would have to compare it with our last RFP to see if there was a significant increase over that RFP. I think that we did back in 2021 or 2022.
I would comment, I think this RFP cycle is probably a little bit more complicated than previous ones, because you're asking for a variety of things. You're asking for plan designs that do not currently exist. You're asking for funding alternatives that are not in place today. So it's, again, the intent of the RFP, and I think JLMBC agreed, was let's take a full breadth approach and see what we get back, and then apply what works. So I think some of those questions we're trying to ferret out. Okay, if I so a good example, we've historically worked off what I think we'll describe as a bundled approach. Anthem provides multiple lines, different lines of medical coverage, HMO, three ways. So essentially 3 different HMO networks plus a PPO. So that's 4 plans. Okay. In this RFP, you're also requesting kind of one-off or kind of exclusive kind of arrangements, and be like, okay, who's going to do that? And if I only do that, am I still going to be considered? How does this get weighted or counted? And so a lot of the questions we're, I think, trying to ferret out. Okay, how do I respond effectively so that I can position myself as best I can? And I think as a starting point with those that have chosen to bid, you've got, I think, 4 good, solid kind of vendor partners to look at, 2 incumbents and 2 new, and each bring a little bit something different to the table. And I think we're all, as a team, both staff, Keenan, Siegel, excited to look at those and kind of see what did we get back and how does that fit with us going forward.
Thank you. I was wondering, because those were some of the concerns that we had with the RFC and the way it was written, and how, would they be, like you said, not considered because they didn't do this or that. When you refer to the addendums, that's not for us to see. If they're not attached, is that on somewhere else?
Oh, the addendums are available on Ramp LA,
Okay.
As part of the RFP itself.
That's like the B-band, the new B-band?
Yes.
Okay. Thank you.
Thank you. Any other questions, Marlene?
Thank you. So then we can move on to Committee Report 2511, project and activity.
Thank you. Okay. So for this report, we are going over the project and activity reports for the month of January and February, as well as the upcoming meeting calendar. So first up on page 1 is Anthem Network update. So, we were recently, notified, by Anthem that, their agreement with Adventist Healthcare was scheduled to expire on March 1st. And that, the 6 affected members were sent a notifications letter as such. At the time this report was prepared, we were not aware of this, but Anthem has since then advised the city that, Adventist has rescinded their, notice of termination for the contract, and the current contract will remain in effect while both parties are finalizing a new multi-year agreement. The affected members will be notified regarding this change as well. Next is a Kaiser update regarding the ongoing NUHW work stoppage. So a couple months ago, we had reported that there was a work stoppage with the NUHW at Kaiser. Since then, negotiations have been continuing between both parties. And as of February 12th, Kaiser has presented counter proposals to the NUHW for consideration, and that's where things stand at the moment. Going down to the wildfire impacted employees. So last month, the JLMBC approved recommendations to temporarily suspend the LEL eligibility rules regarding compensated hours for employees directly affected by the wildfires. In that report, we had advised that we had received one member concern, and since the approval of the recommendation, we had received another member concern about the wildfire. Both employees were, we conducted outreach to both employees to inform them of the option to apply for the subsidy moratorium. Now, moving down to page 2, we have a project update on the 2024 open enrollment period. So as of the current time, open enrollment is considered, the 2024 open enrollment period is not considered complete. Details of the coverage and election changes will be presented by TELUS, the LUTP at the upcoming JLMBC meeting. Moving down to the next item is an update on the Affordable Care Act. So, since January, we have worked with Benefitscape, the ACA consultant, to mail approximately about 45,500 1095 tax forms out to employees by the January 31st deadline. But following the mailing, we became aware of an issue that affected about 3,200 1095 forms. Just as background, there are several types of 1095 forms that an employee may receive. The 1095B forms that most employees receive from their medical plan providers normally will list enrolled dependents. The 1095C forms that the city provides to employees normally do not list any enrolled dependents, except for a group of about 3,200 firefighters because of the nature of how their medical plan is set up. For this group, we normally would list their enrolled dependents, but during this mailing, those dependents were not reflected on the 1095C forms. This was brought to our attention, and since then, we have worked with Benefitscape to correct this and to generate and mail out revised 1095 form, 1095C forms to those employees. And lastly, the contract with Benefitscape, our ACA consultant, is set to expire later this year. We are in the process of amending the contract to extend it by an additional 2 years for a total of 5 years. And part of the reason for this is we had looked at our slate of RFPs that are coming up, and we came to the conclusion that we just can't, we need to try to remove some of these RFPs from that list. And this was a good candidate for us to amend the contract and just extend it as opposed to doing another RFP. And that brings this report to an end. Is there any questions or any calendar items that I can take?
The wildfire impacts, there was only 2 staff who reached out, 2 employees who reached out.
Correct. outreach has been lower than anticipated, and in fact, since the time this report has been prepared, we did receive an additional outreach, but still that's just 3 so far. But I think the part of it is that we had just started mailing out those direct bill notices. So as employees are receiving these direct bill notices, we can probably expect that there may be an increase in the amount of outreach that, from employees.
Has there been outreach from the city? Is there some communications that you're doing to people who could be identified as being in that area that may be impacted?
I don't know offhand if we did any direct communication to employees in that area. I do know that we did include communication in some of the wellness communication that we had sent out to employees. And also in the direct bill notices, we are including this information as well.
Is there a way to do some outreach? Because there may be people who, if you send a direct, if you're mailing them the direct billing and their home's on there and they're staying somewhere else, it may take a while to get to them. They may not have had a forwarding address, or they may have been at multiple locations. Maybe they stayed with this family member and now they're staying with that family member. So I'm concerned that if that's the way that they're being reached, there could be significant delays with that. I don't know how many of those direct bills are being returned to the mail gets returned back because it can't be delivered, or what exactly is happening there. So that's something concerned, or even if, maybe their house isn't burned down, but it's not livable. And so they're still evacuated, and I don't know, the mail's still being delivered at that address. Maybe it's piling up or who knows what. So I'm a little concerned that there's so little outreach when we know there's so many people impacted. That's a little bit of a concern there, if there's any other sort of outreach that could be done.
I think we
But I'm
have,
kind of rambling.
no, thank you for that, Shauna, and you bring up very valid points. For at least for the direct bill notices that are sent out, we do send out 2, so it's not that if they fail to respond by the first notice, we are going to terminate the benefits. We do allow at least 2 mailings before we move there. So I think we need to, Paul and I would need to discuss to see for those direct bill what else we can do. Now, as for, I think, your point about, doing outreach to those areas affected, that may be something that we could look at doing. I just don't know that beyond outside of mailing, we may not have the contact information for those affected employees other than mailing address. So I can see that as a stumbling block in, for us to do some additional outreach. And, we could also look at maybe if we have email addresses for those employees in those affected areas. That might be something that we can look at. That might be viable for us to do, to send email communication. So if they're not able to timely receive physical mail, they may be in a position to be more readily able to access their emails.
Thank you. If there's a way that, if you have some information that you could share with us, like a newsletter, or maybe what was included in the wellness communication, maybe that's also something where, we could do some outreach on our part. We may have personal emails sometimes, or different contact information, that maybe that's another way that we can kind of help with that. So if there's something that you could send to me, let me see if there's something that we can do on our end as well, because as much outreach as we can possibly do to help these members, I don't want them to end up, at the end of the rope, and then they finally receive this notification, or, God forbid, they end up being terminated because they missed this mailing and they missed that mailing, or whatever. And then they're, just overwhelmed by everything. So, as much as we can prevent it from getting to that point, I want to be able to support with that.
Understood, Sharon. I'll talk it over with Paul, but also I just wanted to clarify something that I may have misspoke earlier about about the communication now. There was a recent seminar about the wildfires, and I was just reminded that, as part of that during that seminar, we had provided, sorry, just a clarification. A couple weeks ago, there was a seminar about the wildfire, and we had also provided outreach during that seminar to those employees who had attended that wildfire seminar. I think there was about 30 employees who attended. And that seminar was also apparently recorded for others to view. I don't know where it's posted, but I can find out, where that has been posted. And I think that would be one possibility that we could share, with you, Sean, and the other meetings as well.
Thank you, appreciate that.
We've done, targeted text emails to the zip codes.
Okay.
I think we're good. And we do have a program, so we are notifying anyone who calls about that program about. Most people want time.
Yeah. Yeah, I think that what we found so far is that, the benefit subsidy, there's the employees who are being affected by this have other more different concerns than the subsidy.
Thank you. Appreciate it. Thank you. Do we have any request for a future agenda item? No, all right. Right on the dot, 11 a.m. Look at that.
Thank you.
Everyone.
Thank you. This weekend? Oh, no. Yeah.
Computer died, so then it called me out of the meeting.